I think we're recording. All right, it looks like we're recording now. Okay, thank you guys for your patience. Sorry for the little bit of a slow start this evening, but thank you for joining. Let's see. So tonight I'm going to go through our week 3 assignments. Week 3 is pretty heavy. So week 1, I think you have like 2 assignments. Week 2, I think you have about 2 assignments. Week 3, you have 5. So, and some of them are not the easiest assignments. So one of the assignments, for example, is the portfolio as well. And then you also have a resume. Sorry, it looks like I have some people in the lobby, but I don't see anybody waiting. Weird. Never know what Teams is going to do. So I apologize. Also in advance, I have 3 Chihuahuas and I have somebody who's about to come home from a road trip. So if you see if you hear a cacophony of barking in about 10 or 15 minutes, that's okay. They might bark the house down, but they might not. I just never quite know what they're going to do. They're kind of, I call them chi dramas because they're not Chihuahuas, they're chi dramas. Um, Okay, so let's get started. I'm going to share my screen and we're just going to get started with our week 3 stuff. For week 3, I like to just kind of go, excuse me, directly into Blackboard, and show you what we're looking at here. So what I'm looking at, this is our class in Blackboard. Mine's going to, of course, look a little bit different than yours, but here I am. I'm on the content page, and I'm going to go into week 3. Okay, so let's see, week 3. Like I said, week 3 is a pretty heavy week. There's a lot of stuff going on in week 3. So I'm going to go through kind of just the basics of these assignments, and then I'm going to dig into some of these ones that have are a little bit more complicated. Okay, so week 3, first thing, faculty hidden from students. Okay, first thing here, we have live web call directions and the live web call reflection drop box. So if you're on the live web call now, no need to worry. I'm going to be pulling attendance, and I will enter your attendance, which will count as your assignment grade for the week 3 live web call. If you're watching the recording, you will need to complete a written reflection, just about a couple of sentences. It doesn't have to be long, 75 words or so, quick reflection, and you're going to enter that in the Dropbox for a week 3 grade. So that's, if you're on the call, check, right? Got that one done. Next, we have our lecture. So you have the lecture. This is the this is the document, and this is the interactive lecture. Sorry, I thought these were normally in a different order. So you have your interactive lecture, but don't forget, and this is not just for week 3, but for all of the lectures in this class, you're going to want to make sure you open up that document and save it. Print it out, save it, whatever you got to do. Once you're done with your program, you will not be able to access these classes. And so you won't be able to access the lectures. One of the things with this program is we don't have a textbook. Excuse me. And so if you're studying, right, if you finished your program and you're still studying for your test, you won't be able to access the lectures, right? So that's why you need to download them now, put them on your computer so that you can use them as a resource to study when you're done with your program and you're getting ready to take your test. So lecture, download it. Check. Okay, discussion. What are we doing for discussion today? Oh, so discussion is radiology and lab and path. So we will talk about that. So let's just put a pin in that really quickly. We're going to come back to discussion. It keeps going. I told you, week 3 is a lot. Week 3, resume and cover letter. So I am going to dig into the resume really quickly. Okay, so what this is supposed to be is a real working resume, right? Don't freak out if you've never created a resume, or if you haven't worked on your resume in like 15 years, you're going to be okay, right? So this is your opportunity to create a real working resume that you can use once you graduate from this program, right? So it's just a rough draft, right? It's not some sort of beautiful finalized thing. It just needs to be a working document. And one of the things that I always tell students is make sure, or even job applicants, is again, your resume should be a working document. This is going to be something that I update my resume on at least an annual basis. I have like my 2022 version, my 2023, my 2024, my 2025. At the beginning of next year, I'm sure I'm going to create a 2026. So it's something that you should always be updating. And so after you've created your resume for this class or for this assignment, as you finish out your program, as you take a certification and pass a certification exam, as you get an entry-level job or any other kind of job, you're going to want to add to it, right? So don't just like say one and done resume. No, it's a document that should kind of follow you throughout your professional life, and add things that are relevant. Another thing is you want to really highlight the things that are relevant in this resume or for any job, I should say. If you're applying for a job in, I don't know, hotel management, you want to emphasize your experience in customer service or hotel management or any other experience you've had in a hotel, right? If you're Same thing goes for medical billing or coding. If you want to work in medical billing or coding and you have past experience in hotel management, well, what are those skills that are going to like convey right into medical billing or coding? Well, you definitely have customer management, customer skills. You have to talk to people on the phone. You have to worry maybe about collections, working at a front desk, that kind of stuff, right? So kind of like go through and think of what experience you do have and how it might be transferable into a medical or billing or coding kind of a situation. So even if you don't have any experience, try to find those nuggets, right? What else? And then, yeah, keep it up to date every year. You want to create and update. It's a working document. Update that document. Um, what are some other tips here? So again, I just really don't want you to be too, people just get super nervous. So don't be nervous, right? This is your opportunity to kind of take a stab at the dark, create that resume. So what I'm showing on the screen here are some helpful resources. So you have your week 3 resume and cover letter. That's your assignment. Then you have the DMBC resume template example. So that gives you a good example. You can plug and play in that template. Excuse me. You can also use another template in Word, right? Like my resume I created, I don't know, however many years ago from some template I found at the time, and I just kind of keep adding to it. Use a template. Don't just try to like free text it. You're going to want to use a template. It really helps you with the formatting. Sometimes the templates are a bit of a bugger. I guess, can I say that word? But yeah, just use the template. It really is going to help. And then here you have this last link. It says skills for entry-level medical coders. Read through that. These are going to be skills that you can plug into your resume, right? Things like HIPAA, medical billing, CPT, HCPCS, ICD-10, right? All of that stuff you're learning. I have also in the announcements, here it is. I have added some resume tips. So click through these tips. Again, this is I put it in the announcements as well as the discussion. And one of the things here is, okay, well, I haven't taken my CCA exam. I haven't taken my coding certification test yet. So how do you put that in a resume, right? You can put it just like this, where I've highlighted here in blue. It's certifications, CCA or CPC or CCS or whatever it is, Certified Coding Associate, expected August 2025, right? Actually, I should probably change that date, right? Expected in May of 2026, right? That way the job, the employer knows that you are expecting to take it and they know when you are expecting to take that. Ebony, do you have a question?
Yes, oh wait.
You're good. Are you there?
Oh yes, I haven't had any experience in the whole coding thing, but I've had past experience with like, customer service, being a manager, that type of field, like, you know what I mean? In
Mm-hmm.
customer service. And then I took like about like maybe like 4 or 5 years off due to being a stay-at-home mom.
Okay.
So I don't know how to put that in there.
That's a good question. And that's a lot of our students are in that same boat. You didn't work for the last 10 years. You've been staying at home watching kids, or you've been You maybe just been out of the workforce, right? Maybe you've been staying home taking care of a family member. Just so if you have a gap in your resume, that's perfectly fine. Just make sure you explain it. So just like you explained it to me, right? I didn't work for the last, so from 2020 to 2025, stay at home mom, right? Or you could just, you have to recognize it somehow. Let's say you just didn't work at all. So you could say 2020 to 2025, um, out of the workforce, right? So don't just like expect an employer not to notice, right? They will notice. But give us an explanation. It doesn't have to be super detailed or involved, right? It could just say taking care of family, um, dealing with personal issues out of the workforce, simple as that. Just some sort of explanation. Ebony, I didn't realize that that wasn't you. Do you have a question? If you were talking, you were on mute. We couldn't hear you. If you're talking, we can't hear you. Okay. I see your hand up, so I'm going to keep going, but I'm not hearing a question. So if you want, you can add it to the chat and we can answer it. If not, just kind of interrupt me once. I don't know if that helps. um, okay, what's next? All right, so that's the resume. I'm going to go back to content. Let's go back to week 3. All right, so again, resume, make it a real working resume. The goal, again, for this program is for you to graduate so that you, with something, an employable skill. Oh, Ebony, you can't hear. I think you guys can hear me. So Ebony, if you can't hear, it's probably your settings. You might want to go out and back in again. Um, okay. Okay, so I'm going to keep going. So again, resume, yes, good to go. All right, next on portfolio project, I'm going to come back to that, but let's talk about the check-in. The last assignment here for this check-in, the last time assignment for week 3 is a check-in. This is just a quick check-in. So I keep using that word check-in. You don't hear anything either. Can you guys hear me? Give me a thumbs up. Who cannot hear me? Could you give me a thumbs down? Thumbs up, thumbs up. Okay. Okay. I'm gonna keep going. I'm gonna you who cannot hear me try logging out. Okay, thank you guys. Okay. Sorry, we don't usually have these kind of technical problems. All right, so I'm gonna keep going then. So the check-in, it's just kind of an opportunity for me to check in on how you're doing. How are you doing? Are you really struggling? Sorry, we got all sorts of stuff happening this evening. So yes, the check-in, just give me a brief rundown of how you're doing. If you have questions, if you have problems, if there's anything I can help you with. That's your last assignment for week 3. All right, so let's go back to some of these other assignments. Now, I skipped over the discussion and I skipped over portfolio. Let's do the portfolio first because the portfolio can be a little bit complicated. Um, And I want to show you how to find all of these documents. The reason why it's very important. It is worth 20% of, I think it's 20 or 25% of your grade. I'll have to check. So it's a very important assignment. There's multiple components to this assignment. You're going to have the week 3 portfolio in week 3, week 4, week 5, and then you're going to revisit it again in week 7. Okay, so you're going to have it multiple times throughout this class. The way it kind of works is you're going to complete your week 3 portfolio. You're going to turn it into me. I'm going to grade it. And when I grade it, I'm going to provide you with feedback. So if let's say you got a code wrong, or maybe you got points marked off because your reflection wasn't long enough. We need you to like add more to your reflection. Make those changes. Okay, so use the feedback and incorporate the week 3 feedback from your grading into week 3. So make the change, excuse me, wait, make the changes. You're going to do the same thing for week 4 and then in week 5, right? So you're going to turn it into me. I'm going to grade it and give you feedback. You correct the things you got wrong, if you got anything wrong, and then you turn it all back into me again with the corrections made in week 7, along with a final reflection. The final reflection, I believe, is 75 words about just kind of like reflecting on the entire process for that portfolio, right? So again, weeks 3, 4, 5, you're going to code out some notes, and I'm going to go for every week, every weekly live session, right? I'm going to go in and kind of we're going to walk through the portfolio, right? I'm not going to just let you try to do it yourselves, right? Because there are some things, there's a lot of kind of nuances to some of those. And I'm going to show you that here in a second. So yeah, turn it in, I'll grade it, you make the changes, and you give it all back to me together on one document for week 7. And that's your final portfolio submission. All right, so let's talk about these documents. The documents can be hard to find, right? So here it says week 3 portfolio project, Jane Smith's Encounter. You will complete a portion of your portfolio project. For detailed directions, please refer to the portfolio project directions and rubrics document available in the course assessments folder. Okay, to access the encounter note, please refer to the link below. All right, so if I click on this link, portfolio project encounter note, I'm going to open it up. And this is all we have. It's just an encounter note. Encounter note for Jane Smith. Jane Smith, a 55-year-old female, presented to my office, la, la, la. Okay, well, what do I do with this, right? I'm going to show you. So remember, it says, please refer to the portfolio project directions and rubrics document in the course assessments folder. So here we have the note, but now we have to figure out what we're supposed to do with this note. So I'm going to go to the course assessments folder. So in content, you will find a course assessments folder. I'm going to click on that, open it up, and you'll see that it's a folder of all of the course assessments, obviously, right? That's why it's called course assessments. But this is going to be where you're going to find the portfolio project directions and rubrics. And look at all these links we have here. You will complete parts of your portfolio project throughout this course. Please download and print the document linked below to keep track of all directions and deadlines. Okay, so I'm going to click on the directions first. All right, 20% of our grade. So this is the directions. Look at the directions really quickly. This portfolio project is worth 20% of your grade. So again, it's a heavy hitter, right? If you miss if you get 100% on everything in this class, but you don't do the portfolio, you're only going to get an 80%, right? Because it's worth 20% of your grade. So it's pretty big. I'm going to skip over these outcomes just so we can skip down to the scenario. So the scenario is, you're working in a physician's office as a certified medical coder for ABC Medical Group. As a medical coder, you're responsible for reviewing patient medical documentation, identifying what information needs to be reviewed and taken from that documentation, i.e. abstracting, and then assigning the correct codes that's supported by the medical documentation. One of the important reasons for accurate code assignment is to ensure that services rendered are reimbursed appropriately. So you'll see we're going to kind of at closer to the end of this class talk about reimbursement a little bit. And then directions. So what am I supposed to do? For this project, you will review medical documentation, which will be provided in Blackboard. That's that encounter note we just found. And you will identify evaluation and management service codes, CPT procedural codes, modifiers, and HCPCS equipment/supplies codes if applicable. You will record the identified codes in the coding template that you will download in Blackboard. For each deliverable, you'll add additional codes to the template, and the completed coding template will serve as your final portfolio project. Sounds like a lot, but it's manageable, I promise. So basically, this is talking about a coding template. I think the biggest thing you need to look at here is this coding template. So here I'm back in the course assessments in Blackboard. I'm looking at this portfolio project coding template. Make sure you download and use the template. The template is going to tell you what questions you're supposed to answer. It never fails that I have one student in one of my classes each session who just like grabs the encounter note and starts to code off of it, but they don't get any of the questions right because it's more, the questions are more than just what code would this be. Sometimes you're talking about modifiers, sometimes you're talking about CCI edits, which we'll talk about, right? So there's other questions that you have to answer other than just what would the code be, right? And how do I know what questions to answer? It's on the template. So we have our template. Let me make it a little bit smaller. So here you can see this is week three's template, Jane Smith's encounter. So we're going to use Jane Smith's encounter note. We already saw that. We have 4 little boxes. This one, this one, this one, and this one. We're going to do these tonight. I'm not going to leave you hanging here. Week 4, that's next week. You got some more boxes. Week 5, that's the week after, you got some more boxes. And then here's your week 7. And so this is what I mean by each week, you're going to turn this document into me. I'm going to give you feedback. You'll make the corrections, then turn it back into me with the next week. I'll give you, go back and forth, ping back and forth until you have it all completed. Beautiful. You've made all of your corrections. So by the end of week 7, you should have 100% on this assignment, right? For week 7, because you will have made all of the corrections. Let me go back here. Okay, so before we go in and just start coding this out, I do want to go back here just for a second. So again, you got your directions, we have our template, and then all of the notes that we're going to be using to code this out are also right here for us. So we've already opened up, I've already downloaded and encountered this downloaded and opened the encounter note. That's the one we're going to use for tonight. Next week, we're going to do imaging and pre-op labs. And then the week 5, we're going to do this operative note. Okay. So let's do it. Do I have any questions before I kind of go in and find out where I'm at here? Nope. Okay. All right. So in order to get, again, I'm going to make this one. Whoa, I don't want to make it that big. We're going to make it just this big. Okay. So week 3, Jane Smith's encounter. So CPT E&M coding, after reviewing Jane Smith's documentation and the CPT E&M guidelines, answer the following questions. First question, what is the appropriate CPT evaluation and management code if it's determined based on time spent? Okay. Number 2, what's the appropriate CPT evaluation and management code when determining it based on the level of medical decision making? Excuse me. And then number 3, what is the accurate E&M code? So we're going to have to level it based on time. We're going to level it based on MDM, and then we're going to assign a code. And then the last question is always going to be reflection. How did you find this code? Not just like, don't give me just like the steps to coding, like step 1, step 2, step 3. No, tell me how you actually found this code, right? What did you consider? What page did you go to? Why did you select this code versus that code? That kind of a thing. All right, so what this means is we're going to have to figure out the E&M code for this patient. So let's go to the note, encounter note. So here we have Jane Smith, a 55-year-old female, presented to my office for a follow-up regarding recurrent carcinoma of the left breast. Stop right there. Okay. Now remember, when we're coding for E&M coding, and I put this in the notes, if you guys missed the week 2 live session, if you're totally lost for E&M, go back to the week 2 live session. I also put this in the notes in the announcements as well as the discussion for week 2. So when we're coding for an E&M, we have to ask ourselves a couple of questions, right? The first one was, what is the setting? What is the type of service? The questions are, what is the type of service? Was the patient new or established? What was the patient status? And what was the setting of the service? So in this case, it's an office visit, right? So remember, in order to identify the correct E&M code, if you have your CPT code books, go ahead and get those babies out. Let's figure out this code. You're going to want to go to page 1. Hopefully you're tabbed at this point, right? I don't have my little, my technical problems tonight. I don't have my camera, so my book camera. So we're just going to have to go with it like this. So make sure you get your CPT code book, go to page 1. The reason why I referred to tabs is because it should be your very first tab right there. It's on page 1, right? It's the first red page, the first page with the red edge. That's what you're looking for. Page 1. My screen just went black. Okay, we're good. You know what? I think we're good. Goodness gracious. I don't know what's happening tonight. Okay, so page 1. Going to talk about page 1. All right, so page 1, the way I like to code for an E&M, identify the code for an E&M, is using the table of contents. This is different than using coding for surgical procedures or other things, which we'll look at the end of this, next week's. But when it comes to E&M codes, again, I like to use a table of contents. And if we ask ourselves those questions, what was the type of service? What was the patient status? What was the setting of service? Then that guides us well enough through the table of contents so that we can identify a code range. You can't ever identify the code directly from the index anyways. You can't identify the code from the table of contents, but it's going to give us a range. Then we're going to refer to those codes in the main section of codes and then figure it out, right? Which one is right? So what is the type of service? In this case, it's an office visit presented to my office, and highlight that yellow. All right, now on page 1 in your CPT code books, the second half of that table of contents, under where it says evaluation and management, in green, it says office or other outpatient services. There you go. Code range is 99202 through 99215. All right, halfway there, right? Now the next question, and if we look at our table of contents, it's not, we have 2 subheadings there, right? We have a new patient, or is it an established patient? So now that's what we need to figure out next. Next sentence. She was last seen in my office when she completed treatment 2 years ago, but experienced recurrence following a recent screening mammogram revealing suspicious calcifications. All right, so is she new or established? I'm gonna let you guys tell me that. Is this patient new or established? If she was seen 2 years ago.
She was already sure established patient she came before.
Yes, perfect. Thank you. You're right. So established patient, how do we know, right? So new versus established patient, just so you guys know, that's on page 6 in the CPT code book. You have a decision tree. It looks like this. Essentially, if the patient hasn't been seen in the last 3 years within that specialty or subspecialty in that practice, then she's an established patient. So I'm just going to highlight this 2 years ago.
I'm trying to figure out.
Oh, spelled that wrong. Okay, established patient. And then you can see our little code range is getting a little bit smaller, 99211 through 99215. Oops. Nice. And notice we've got this far without even looking at the rest of them. This is literally the first two sentences, right? All right, so that's as far as we can get. But we know established patient, that those codes are going to start on page 16. So let's go to page 16 in our code books. This is when it gets a little bit more complicated, right? So this is when we have to figure out exactly which code it is. Is it 99211, 2, 3, 4, or 5, right? Now, 99211 is a nurse visit only. If you look at 99211 on page 16, it says office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. So this is what we would consider a nurse visit, not necessarily a provider visit. So if the provider ever sees the patient, you should code at least at a level 2, if that makes sense. So 99211 is just a nurse visit, not a doctor's visit. So that leaves us with 2, 3, 4, or 5. And we know based off of last week, right, you can base that level of code on either time or medical decision making. Now remember, this is asking us for time. So now we need to go into that. Let's go into the notes, see how much time they spent. Okay, so I'm just gonna scan down. I'm gonna go, usually the time is at the bottom of the note. I don't think I've ever seen a doctor document the total time spent at like the top of the note. So I always just go straight to the bottom. And here it is. Here we have, I spent 25 minutes. Um,
Right, mom.
Sorry, I'm looking to see if I see any other time statement. I don't see. Sometimes it'll be I spent 25 minutes and then plus another 5 minutes to review an X-ray or something like that. But here I've got 25 minutes. So 25 minutes equals, so if we look at our codes, now 99212, remember our anatomy of an E&M code. I'm gonna see if I can show this to you. You've got your code 99212. You've got your code description. Down at the bottom, this one says straightforward medical decision making, and then under that it says how much time is required. So for 99212, it says 10 minutes must be met or exceeded. Well, we've got to 25, so let's go down to 99213. A 99213 says when using total time on the date of the encounter for code selection, 20 minutes must be met or exceeded. So here we go. We've got 25 minutes. Let's check 99214 just in case. If you look at a 99214 on page 17, that says when using total time on the date of the encounter for code selection, 30 minutes must be met or exceeded. So in this case, we're over 20, we're not, but we're under 30. So we're stuck at that code. I'm gonna let you guys tell me what code would we put if we were to code this based on time. What code would we report?
99212.
Go up a level. So remember, we have 25 minutes. A 99212 is 10 minutes. A 99213 is 20 minutes. A 99214 is 30 minutes or more. Yeah. All right, good.
So
Yeah. Go ahead.
213 then.
Yep, perfect. 99213. 99213. So there's your answer, right? For this box. Now you don't have to add all of the rest of this stuff. You just give me the code, right? I'm just adding this here, like all this stuff in yellow, just so you guys can see kind of how I got there, right? All right, that's time. Any questions on time before we move to the harder part, which is that MDM? Let's make MDM green. Question?
Since we're going over this all together, do we use this for week 3 project? Like,
Yeah,
do we have
so
to?
I'm giving you the answer a little bit in this case. So yeah, that's the answer.
Okay, so we basically write like basically what we're discussing right now, or do we have to reword it, or?
All you have to do is give me the code. It doesn't have whoa, hang on. That's all you need to put. It's just the code.
Okay.
It doesn't have to be. Yeah, the reason I put all that is just to kind of guide us through the question.
Oh,
Cool. Any other questions? Okay. All right, let's do number 2. So let's find out what is the level of medical decision making here. Now, I don't have it open yet, but hang on, bear with me for a second. And I'm going to open my MDM table. I did add this as an announcement last week. This is the same medical decision-making table that you're going to find in your CPT code books on pages 9 and 10. I just like to show this here because it's all on one page. I like this a lot better, honestly. I'm going to get this just perfect so that I can take a snip. Because I like to write on it. Okay, here we go. So here's our snip. All right, so this is a repeat from last week, so hopefully this will kind of build on itself. So medical decision making, that level of medical decision making, whether it's straightforward, low, moderate, or high, which is a level 2, 3, 4, or 5. That level is determined based on meeting or exceeding 2 out of 3 of the elements. The elements are the number and complexity of problems addressed. That's the diagnosis. The middle is the amount and or complexity of data to be reviewed and analyzed. That's like ordering tests, reviewing or ordering x-rays, that kind of a thing. And then the last column is the risk of complications, right? How risky is this to this patient? Okay, so I usually start with the diagnoses. Here we have minimal, one self-limited or minor problem. Low is 2 or more limited or self-limited or minor problems, a stable chronic illness, and a complicated illness or injury. So let's go back to that note and figure out what's going on with this patient. All right, so she was last seen 2 years ago for completed treatment, and now she's getting a recurrence of suspicious calcifications, a diagnostic, oh, sorry, it's right here, a recurrent carcinoma of the left breast. So this patient is experiencing breast cancer, right? A diagnostic mammogram and stereotactic core needle biopsy confirmed carcinoma of the left upper quadrant breast. Her medical history includes depression managed with Zoloft and hypertension, managed with lisinopril. Family history includes a mother with breast cancer. Okay, so I'm going to stop right there. So if we have a carcinoma of the left upper quadrant breast, in this case, and it's recurring, so I would probably say that it went away and now it's coming back, right? I would not call this a stable chronic condition at this point. It could be you can have a cancer that's stable, right? But in this case, it's coming back, right? So I would probably call this one or more chronic illnesses with exacerbation, progression, or side effects. It went away and now it came back, right? So in this case, I would call that a moderate in terms of diagnosis. Again, if the next time this patient comes in, or if this patient has undergone treatment and, during that treatment, her cancer is stable, right? It's not progressing. It's not getting worse. She doesn't have any kind of other weird side effects. She's just progressing normally, right? Her cancer is stable. Then it could potentially be a stable chronic illness at that time. But today I'm going to call it a moderate illness with a moderate chronic illness with progression. Sorry, because it came back, right? It's progressing. It came back. And at this point, we kind of don't know how bad it is, right? So I'm going to call that a moderate diagnosis. Now let's look at our data. How much data did we review or analyze? Let's see. So on review of systems, Jane denies constitutional symptoms, cardiovascular or respiratory issues, denies. She is currently tearful, consistent with her psychiatric history. I don't doubt why she should be. Here we have a physical examination, revealed a well-nourished female with normal vital signs. Unremarkable examination of her left breast revealed tenderness and a palpable mass, whereas the right breast exam was benign. Remember, we're looking for data here. Discussion ensued regarding treatment options. Considering recurrence, a modified radical mastectomy with axillary lymph node removal is recommended. A PET with CT scan. That's data. That's an order. We're gathering data in this case. That was ordered to evaluate the metastasis that's spreading. Referral to a plastic surgeon for breast reconstruction post-mastectomy advised. Psychological support was recommended. Okay, so we have some data here, right? But it's only one thing. So in this case, data, now in order to get to limited, you need 2. In order to get to moderate, you need 3. And here we have minimal or none. So yeah, even though our patient has a recurrence of breast cancer and we're ordering a PET scan, in this case, she's only at that minimal level in terms of data. So it's going to come down to risk to be our tiebreaker. All right, so let's talk about risk for a second. Minimal risk is essentially patient can go home without being treated and they'll be fine, right? That's not the case what we have here. Low risk is going to be anything less than prescription drug management, less than surgical intervention, maybe over-the-counter meds, maybe wound care, maybe a referral to a dermatologist, referral for physical therapy. That would be low risk. Moderate risk is going, here you have, we have finally have some examples. Moderate risk is kind of when the risk is such that the clinician has to become involved in managing that risk, right? So you have prescription drug management, that's a biggie. And then you have decision regarding surgical procedures. Now, if we don't remember, we did make a decision for surgery here. A modified radical mastectomy with axillary lymph node removal is recommended. That is a major surgical procedure, right? This is the removal of that breast tissue. That is a major surgical procedure. So I'm going to go back to my table here. And here we have decision regarding elective major surgery without identified patient or procedure risk factors. Elective major surgery, that's a mastectomy, right? So here we have moderate risk. So we got moderate for the diagnosis, minimal for the data, and moderate for the risk. You guys tell me what level would we code this? What is our medical decision making supported by the note? Is this straightforward, low, moderate, or high? It's not going to be high, I'll tell you that.
Moderate.
Moderate.
Yeah. Yay, good job. Yes. Moderate, right? So let's look at our table. Let's look at our codes in the book. So now we know that our moderate, I'm going to write it down, MDM. MDM equals moderate. Okay, now let's figure out what code are we going to code here. So we know the other stuff isn't going to change. It's still an office visit for an established patient. So we know it's still going to be within that 99211 through 99215 code range. What do you guys think? I'm going to let you tell me, what is our code? Is it going to be 99212, 99213, 99214, or 99215? Go ahead and look at those code descriptions. Check that level of medical decision making, and you're going to want to match it up to whichever one states moderate.
It'll be 99214.
Yep. Nice. You guys are doing great. 99. Good job. Uh-oh. All right. See what happened there? Now, for the first one, you have a 99213 based on time. The second one, we have a 99214 based on MDM. So look at question number 3 here. What is the accurate E&M code for Jane Smith's visit with Dr. Wells? Which one do we choose, right? We have a level 3 based on time, a level 4 based on MDM. So now in this case, I will tell you that according to CPT guidelines, we can code based on either MDM or time, right? So we could code it based on time, but we could also code it based on MDM. Essentially, what we are allowed to do in this case is report the higher level code. Not only are we allowed to, as far as our CPT coding guidelines go, but it's a more accurate representation of the service that was performed on that date, right? Yeah, it was moderate because this patient's got a recurrent carcinoma of the left breast, and we're recommending a major surgical procedure, right? So in this case, and again, in the future, some people think, I've run into a lot of doctors who think that if time is documented, you always have to code based off time. That's not the case. CPT guidelines allow us to code based off of either. So if time is higher, report the code based off of time. If MDM is higher, report the code based off of MDM. So yes, those of you in the chat, right, you're going to report a 99214. Pink, hot pink. All right. Any questions on any of that, how we got there, or why we're going to choose a 4 rather than the 3? Okay, number 4, this last box, I'm not going to delete it. I'm going to let you guys do this yourself. So again, provide me a rationale. Why did you choose 3, 4, 3 or 4 or 5 or whatever you chose? Give me at least 75 words or more. Not 745, 700. It's a Monday, y'all. 75 words or more.
Oh, I thought she said 700. I could say, Lord, she don't have to give me a chance.
Just 75 words. When would time be chosen over MDM? That's a good question. So usually in the real world, what I tell my clinicians is if a patient comes in for a low level condition on which the clinician, the doctor, spends a high level of time, that's going to be an indication that you should code based on time. So I have a really good example. Actually, I came in once. One time I had a patient who called regarding a complaint. We had an encounter that was billed at a level 5, which is the highest level, right? And it was coded based on time. It was like 45 minutes, over 45 minutes. But the patient had come in for a ruptured eardrum. And this is an adult, and a ruptured eardrum, it might sound bad, but it's actually a very minimal kind of the eardrum just heals right over, right? It's not a big deal. It happens all the time. And so by all means, the MDM should have been low, but, right? So you're talking a low level, potentially low level condition. But in this case, this woman, she presented to the urgent care and she had gotten her eardrum ruptured by a palm frond, like from a palm tree. You know, the leaves are really pointy. Somehow this lady got got a palm frond in her ear and it punctured her eardrum. And so not only that, right, that's how it happened, but then this, she said, and this was all documented, this is all in the documentation. According to her, the same thing had happened to her friend who had gotten her eardrum punctured by a palm frond, and she got some kind of crazy bacterial infection because apparently palm fronds have some sort of strange bacteria. And because of this, she was really concerned about some sort of potential bacterial infection from the palm tree leaf. And so she asked the clinician who documented all of this to make sure that whatever antibacterial or antibiotic she made him like, he called the pharmacist, had a lengthy discussion with the pharmacist to determine what antibiotic would be most appropriate to treat a ruptured tympanic membrane because the lady had been punctured by a palm frond, right? So in that case, right, I'm going on a tangent here, but in that case, right, it should have been a low medical decision making, which would have been a level 3, right? But the provider spent a heck of a lot of time managing this patient's condition. He spent 45 minutes trying to figure out what antibiotic and having discussions with the patient. And so he documented 45 minutes. So she called and she was like, it was just a tympanic membrane, you know, it was just a rupture or whatever. And we were like, yeah, but documentation supported 45 minutes of time was spent because of this, and this. So yeah, a high level of E&M code was reported accurately for that encounter. So kind of a funny, a very funny kind of example, but you know, I think it's a good example. So again, you would report, usually, yeah, you report time when time is higher than the MDM. All right. What time is it? We have about 8 minutes left. And let's go back to where we were. All right, so going back to week 3, I'm going to switch gears pretty quickly here. And I think we have enough time to do this. We might go over by just a little bit. So we skipped over the discussion. I'm going to copy these. For some reason, it never wants to copy case number 4. Hang on. Let me format this just a little bit. Okay. So let's switch gears for a minute. I have a little bit of time to do this, and I could probably spend the next 20 minutes doing this, but I honestly kind of have a hard stop at the end of the hour. So I'm going to go into this really quickly. Now, case number 1. So this week, we're going to talk about pathology, path and lab, and radiology services. Case number 1 and case number 4 are both radiology services. Case number 2 and case number 3 are both lab and path services. one of the ways I like to teach coding is to kind of have you guys give you guys questions that you would ask yourself, right? And so one of the first questions that you would ask yourself when presented with a radiology coding case, let's look at it. It says a patient went to Vista Imaging Center and Dr. Smith performed a CT imaging of the left leg with contrast. Vista Imaging Center is a facility where the radiologists own the equipment and read and interpret their own studies. What is the appropriate CPT code and modifier if applicable? All right. So one of the first questions you want to ask yourself when you're coding for radiology is what imaging service was performed? Was it an X-ray? Was it a ultrasound? Was it a MRI? Was it a CT scan, etc.? Right? I'm trying to think, right, if there's anything else, right? That's pretty much the first asked question. Well, what am I coding for, right? Is it an X-ray? Is it an ultrasound? What is it? So in this case, what imaging service was performed, let's highlight this guy blue, it was a CT imaging. Cool, done, right? Let's look at the next question. Weird, okay. The next question is what area of the body was imaged? Okay, well, right, we're not just going to take a picture. Sometimes the image is of the entire body. Sometimes we have PET scans or some nuclear medicine procedures that literally image the entire body, but those are going to be relatively rare, right? So you're gonna, usually we're looking for something. We're looking at something. Was it an ultrasound of a pregnant fetus? Was it a fracture of the leg, a potential fracture of the leg? You're going to image the leg, right? So what area of the body was imaged? So I'm going to put that in green. So here it was the leg. Going one step farther, and this is an especially important question when it comes to diagnostic radiology, is what was the laterality? Laterality. Laterality. Laterality is right or left side. Right? So in this case, I'm going to put this a little bit different. I'm going to change my highlighting up for a second. If you can't tell, I used to teach face-to-face and I used to really like to write on the board. So I don't have a board to write on anymore. This is the next best thing. Okay, leg, CT of the leg. What was the laterality? In this case, it was left. Let's make that gray. Now, when it comes to the laterality, if you don't remember this from the very, very quick discussion of modifiers last week, there is a modifier. Add the appropriate laterality, if I can write, RT, LT, or 50. Okay, so well, let's see. This is why I say this is important when it comes to radiology, is because typically the procedure is performed on either laterality or sometimes both sides, right? And so let's see, you would add the appropriate laterality modifier. So if we identified, if it is a paired organ, like the legs, right? You have two of them. The body is symmetrical, right? You got two legs, you got two arms, you got two ears, you got two eyes, that kind of thing, right? So if it is a paired organ and you only did that procedure on one side and the procedure is a unilateral procedure, you're going to want to add the appropriate modifier to identify the laterality of the procedure. So in this case, you're going to want to add LT. Whatever code we figure out for this encounter, we're going to add LT to that. Messing with my numbering here. Okay, next question is, another question is the number of views. Sometimes, and I'll talk about this here in a second. So sometimes for an x-ray specifically, we'll do multiple views, right? So like my daughter, when she was in 4th grade, like most 4th graders do, she fell off the monkey bars and broke her ankle. Broke her wrist. And so like we're in the urgent care, and the urgent care lady, she's like, do this. And she did an x-ray with her thumb up, and she like did an x-ray with her crossing her fingers, and she did this view and that view so that she could see all the different views. So one of the major components of x-rays is the number of views. Now, this one you can see, we don't have a number of views. But if I scroll down to this case number 4, we have a patient who went to an outpatient hospital imaging center and received a 3-view chest x-ray. So you want to make sure that whatever code you do select, sometimes it's a component of your code, sometimes it's not. If it is a component of your code, you need to make sure you count for that appropriately. So in this case, for case 4, you would select a 3-view chest x-ray. So that one's not a component for case 1 though, so doesn't matter. All right, number 4 next is going to be with or without contrast. I'm going to say just contrast. We have with, we have without, or we have with and without. Usually it'll say without followed by additional. Okay, contrast. Okay, so what is contrast? Contrast is a material that is injected into the patient. In order to code it as with contrast, it has to be something that's injected into the patient. It can't be something that they inhale. It can't be something that they ingest. It has to be like done with a needle, right? Contrast material is a material that's injected into the patient to essentially just give us different, right? It's absorbed at different rates by the body's cells. So you could take a picture with contrast versus without contrast, and you're going to get a different image, right? So some procedures are done with contrast. Some procedures are done without contrast. Sometimes you have with and without. And so once you administer the contrast, it stays in the body for a while, right? So in the code description, it's going to say something like without followed by an additional series with contrast. They take the pictures without contrast, then they give the contrast, and then they take additional pictures, right? So in this case, Mr. Broken left leg here, or whatever is wrong with his leg. What color did we not use? Red? Yellow. We haven't used yellow. With contrast. Okay, so here we have with. All right, and that's going to be in the code description, right? You're going to see that in the code descriptions. It'll say with contrast, without contrast, or without followed by with. And the last thing. Last question is, what component are we billing for? Now, in order to understand components, let's think about what a component is. Let's think about how an x-ray is performed, right? How do you do an x-ray? So like my daughter, she's in 4th grade. She falls off the monkey bars. She's got a broken wrist. I take her to the urgent care. This urgent care is a freestanding urgent care. They have an x-ray machine, and they have a doctor who works there on call who reads and interprets the x-rays, right? They own the x-ray machine. So I take her in, right? We go into the back. We have an x-ray tech who does the imaging service. That x-ray tech, does all the different views, works the x-ray machine. We don't like produce the actual images on film anymore, but those images are like recorded onto a device. That's that technical component. There's like that technical half of it, right? The doctor, on the other hand, the doctor who does the read, the doctor who does the professional component is going to provide an interpretation and report of the images, right? So this is the doctor looking at those x-ray images and saying, oh, it looks like we have a green stick fracture of the left distal radius, blah, 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 right? That's the provider doing their, like, I'm a doctor kind of thing, right? They're determining the patient's diagnosis. Does the patient have a diagnosis? So they provide their interpretation, which is a diagnosis, and then they provide that report. So those are kind of like the two halves of most radiology services, right? You have that technical component and a professional component. Now, why does it matter? It matters because sometimes not both components are going to be performed by the same facility or clinic. So in the example that I just provided, we have an urgent care facility. They have their own x-ray. They employ the x-ray tech. They also employ the physician who is reading and interpreting and providing the report for those studies. So what they performed is what we call the global. I'm just going to say global charge. It's not a global component because it's the whole thing, right? So the global is both of those components put together. Cool. Now, let me give you another example. So let's say we have a pregnant female. She's got a high-risk pregnancy, and she has been ordered by her OB, her maternal fetal medicine specialist, to go to an imaging center to get an ultrasound. Okay, so our maternal fetal medicine specialist is at this clinic. They do not have their own ultrasound machine, right? Meanwhile, the patient goes to the imaging center. The imaging center is where she goes to get her ultrasound. The imaging center doesn't do anything except for the ultrasound. The patient goes in, she gets some jelly on the belly and gets the ultrasound, right? Then the ultrasound company produces the records and sends it to the maternal fetal medicine specialist. And then the maternal fetal medicine specialist reads and interprets the ultrasound. So here you have two completely separate facilities, two separate billing entities doing separate components of that procedure, right? So in this case, it's the same CPT code. It's the same ultrasound CPT code, right? But in this case, we have to break it in half, right? So the imaging center would report the technical component. So they would report the CPT code with modifier TC, TC for technical component. And then the maternal fetal medicine specialist, on the other hand, the one who did the interpretation and report, she's going to go ahead and repeat that same ultrasound code with modifier 26. Modifier 26 is in your CPT code books in Appendix A, and that identifies that it was the professional component. So when that happens, it's the service is broken in half pretty much. And so reimbursement will change. Not $60, 60%. 60% reimbursement, usually. Okay, so again, you kind of broken in half, right? So the technical component will typically result in about a 60% reimbursement of the allowable amount of that charge, whereas a 26, a professional component, is going to result in about a 40%. They pay a little bit more for the technical, typically, because the machines are very expensive, right? Now, if you do the entire thing, if you do the global charge, you don't report any modifier. There is no modifier for like the global component. You just report the code. And then you get, hopefully, you get 100% reimbursement. Okay, so now let's look at our example here. Let's look at this sentence. It says, Vista Imaging Center is a facility where the radiologists own the equipment, okay, and they read and interpret their own studies. So they own that technical component, they perform the technical component, they also do the professional component. So in this case, let's highlight this. Oh goodness, not that. What are all these colors? Red. Lost my cursor. In this case, it would be global. We wouldn't put any modifier there. let me go down to case number 4, and then I know we are I do have to call it a night. So let me talk about case number 4. Patient went to an outpatient hospital imaging center, received a 3-view chest x-ray at the hospital, right? We got an x-ray of the chest, 3 views. Notice that there is no mention of contrast here. That's because contrast is not available, right? If there's no option for contrast in the code descriptions, then it's not something we need to worry about. Kind of like in the other example, we didn't have the views. Now, look at this last sentence. It says, what is the appropriate CPT code and modifier, if applicable, for coding the technical component of the chest x-ray? So in this case, if you have case 4, you want to make sure you use I don't know. I can't even type at this point. You're going to want to report the code with the TC modifier. Why? Because it asked us to, right? Yeah. Okay. So we're about 10 minutes over at this point. I am going to call it a night. I do have another little recording that I have completed. It's about 8 minutes or so. And I'll post that. It goes, it's pretty much the same thing that we just went over. But I go into the lab coding just a little bit as well, I believe. So I'll post that in the announcements and the discussions so you guys have access to that. It's a YouTube link. It's like 8 minutes. Sorry. But yeah, that's it. That's a lot. I know this is a lot. So before we call it a night, do we have any questions about radiology imaging?
No, ma'am.
All right, thank you. Okay, well, I'll stay on for the next couple of minutes. I'm going to stop recording. If you want to stay on, again, I'll stay on for the next minute or so. If you need to drop, go ahead and do so. If you have questions, I'll stay on for a minute. If not, have a great night, happy coding, and please reach out to me if you need anything.
You as well.
Thank you.